Pituitary tumors.
Introduction.
The pituitary gland is a small, bean-shaped gland situated at the base of brain, somewhat behind nose and between ears. Despite its small size, the gland influences nearly every part of body. The hormones it produces help regulate important functions, such as growth, blood pressure and reproduction. Definition. A tumor is an abnormal growth of cells. Tumors can start nearly anywhere in the body. Tumors that start in the pituitary gland are called pituitary tumors. A pituitary gland tumor is a group of abnormal cells that grows out of control in pituitary gland. Most of these tumors are not cancerous. Pituitary cancer is very rare. Pituitary tumors are abnormal growths that develop in pituitary gland. Some pituitary tumors can cause pituitary gland to produce lower levels of hormones. Most pituitary tumors are noncancerous, benign, growths, adenomas. Adenomas remain in pituitary gland or surrounding tissues and don't spread to other parts of body. Risk factors. If client has a genetic condition, a defect in one or more genes. Some conditions may make to get pituitary tumors, such as Carney complex, rare genetic disorder that causes many noncancerous tumors. Familial isolated pituitary adenoma, or FIPA, rare condition that makes body grow larger than normal. Isolated familial acromegaly, similar to FIPA. McCune-Albright syndrome, rare condition of that shows up as abnormalities in bones and skin. Multiple endocrine neoplasia, type I and type 4, MEN1, MEN4, disorders that can cause tumors in glands. Causes. The cause of uncontrolled cell growth in the pituitary gland, which creates a tumor, remains unknown. A small percentage of pituitary tumor cases run in families, but most have no apparent hereditary factor. Still, scientists suspect that genetic alterations play an important role in how pituitary tumors develop. Types of pituitary tumors. Benign glandular tumors called pituitary adenomas. Malignant tumors, called pituitary carcinomas. Pituitary adenomas. These benign tumors do not spread outside the skull. They usually stay in the sella turcica, the tiny space in the skull that the pituitary gland sits in. There is very little room for tumors to grow in this part of the skull. So, if the tumor gets larger than about a centimeter, about half an inch, across, it may grow upward, where it can press on and damage nearby parts of the brain and the nerves that arise from it. Microadenoma versus macroadenoma. Pituitary adenomas can be divided into two categories based on size. Microadenomas are tumors that are smaller than 1 centimeter, cm, across. Because these tumors are small, they rarely damage the rest of the pituitary or nearby tissues. But they can cause symptoms if they make too much of a certain hormone. Many people actually have small adenomas that are never found because they don't grow large enough or make enough hormones to cause a problem. Macroadenomas are tumors 1 centimeter across or larger. Macroadenomas can affect a person's health in two ways. First, they can cause symptoms if they make too much of a certain hormone. Second, they can cause symptoms by pressing on normal parts of the pituitary or on nearby nerves, such as the optic nerves. Functional versus non-functional adenoma. If a pituitary adenoma makes too much of a hormone, it's called functional. If it doesn't make enough hormones to cause problems, it's called non-functional. Functional adenomas. Most of the pituitary adenomas that are found make excess hormones. The hormones can be detected by blood tests or by tests of the tumor when it is removed with surgery. Based on these results, pituitary adenomas are classified as lactotroph adenomas make prolactin and account for about 4 out of 10 pituitary tumors. Somatotroph adenomas make growth hormones and make up about 2 in 10 pituitary tumors. Corticotroph adenomas make ACTH and account for about 1 in 10 pituitary tumors. Gonadotroph adenomas make LH and FSH and are very rare. Thyrotroph adenomas make TSH and are very rare. Plurihormonal adenomas make more than one hormone. Null cell adenomas do not make hormones. These are non-functional adenomas. Non-functional adenomas, pituitary adenomas that don't make excess hormones, are called non-functional adenomas or null cell adenomas. They account for about 3 in 10 of all pituitary tumors that are found. They are usually found as macrodenomas, causing symptoms because of their size as they press on nearby structures. Pituitary carcinomas. Pituitary carcinomas look like pituitary adenomas under a microscope, so doctors have trouble telling them apart. In fact, the only way to tell if a pituitary tumor is a carcinoma and not an adenoma is when the tumor spreads to another part of the body not near the pituitary gland. Most often pituitary carcinoma spreads to the brain, spinal cord, meninges, the covering of the brain and spinal cord, or bone around the pituitary. Rarely, these cancers spread to other organs such as the liver, heart, or lungs. Other tumors of the pituitary region. There are several other types of benign tumors that grow in the region of the pituitary, as well as some malignant, cancerous ones. All are much less common than pituitary adenomas. Teratomas, germinomas, and choriocarcinomas are all rare tumors that usually occur in children or young adults. They don't develop from the hormone-making cells of the pituitary gland itself, but they can grow into the pituitary and damage it. Rut cleft cysts and gangliocytomas of the pituitary are rare tumors that are usually found in adults. Craniopharyngiomas are slow-growing tumors that start above the pituitary gland but below the brain itself. They sometimes press on the pituitary and the hypothalamus, causing hormone problems. They are more common in children, but they can be seen in older adults. Clinical manifestations. Not all pituitary tumors cause symptoms. Pituitary tumors that make hormones functioning can cause a variety of signs and symptoms depending on the hormone they produce. The signs and symptoms of pituitary tumors that don't make hormones non-functioning are related to their growth and the pressure they put on other structures. Large pituitary tumors, those measuring about 1 centimeter, slightly less than a half inch, or larger, are known as macrodenomas. Smaller tumors are called microdenomas. Because of the size of macrodenomas, they can put pressure on the normal pituitary gland and nearby structures. Signs and symptoms related to tumor pressure. Headache. Vision loss, particularly loss of peripheral vision. Symptoms related to hormone level changes. Overfunctioning. Functioning pituitary tumors cause an overproduction of hormones. Different types of functioning tumors in pituitary gland cause specific signs and symptoms and sometimes a combination of them. Deficiency. Large tumors could cause hormonal deficiencies. Signs and symptoms include nausea and vomiting, weakness, feeling cold, less frequent or no menstrual periods, sexual dysfunction, increased amount of urine, unintended weight loss or gain, adrenocorticotropic hormone secreting, ACTH, tumors. ACTH tumors produce the hormone adrenocorticotropin, which stimulates adrenal glands to make the hormone cortisol. Cushing's syndrome results from adrenal glands producing too much cortisol. Possible signs and symptoms of Cushing's syndrome include fat accumulation around midsection and upper back, exaggerated facial roundness, thinning of the arms and legs with muscle weakness, high blood pressure, high blood sugar, acne, bone weakening, bruising, stretch marks, anxiety, irritability or depression, growth hormone secreting tumors. These tumors produce excess growth hormone, acromegaly, which can cause coarsened facial features, enlarged hands and feet, excess sweating, high blood sugar, heart problems, joint pain, misaligned teeth, increased body hair. Children and adolescents might grow too fast or too tall. Prolactin secreting tumors. Overproduction of prolactin from a pituitary tumor, prolactinoma, can cause a decrease in normal levels of sex hormones, estrogen in women and testosterone in men. Excessive prolactin in the blood affects men and women differently. In women, prolactinoma might cause irregular menstrual periods, lack of menstrual periods, milky discharge from the breasts. In men, a prolactin-producing tumor may cause male hypogonadism. Signs and symptoms can include erectile dysfunction, lowered sperm count, loss of sex drive, breast growth, thyroid-stimulating hormone-secreting tumors. When a pituitary tumor overproduces thyroid-stimulating hormone, thyroid gland makes too much of the hormone thyroxine. This is a rare cause of hyperthyroidism or overactive thyroid disease. Hyperthyroidism can accelerate body's metabolism, causing weight loss, rapid or irregular heartbeat, nervousness or irritability, frequent bowel movements, excessive sweating. Diagnosis. To diagnose a pituitary tumor, the doctor will likely take a detailed history and perform a physical exam. Blood and urine tests. These tests can determine whether a client has an overproduction or deficiency of hormones. Brain imaging. A CT scan or MRI scan of brain can help judging the location and size of a pituitary tumor. Vision testing. This can determine if a pituitary tumor has impaired sight or peripheral vision. Management. Treatment involves a team of medical experts, possibly including a brain surgeon, neurosurgeon, endocrine system specialist, endocrinologist, and a radiation oncologist. Doctors generally use surgery, radiation therapy and medications, either alone or in combination, to treat a pituitary tumor and return hormone production to normal levels. Surgery. Endoscopic transnasal transsphenoidal surgery. Surgical removal of a pituitary tumor usually is necessary if the tumor is pressing on the optic nerves or if the tumor is overproducing certain hormones. The success of surgery depends on the tumor type, its location, its size, and whether the tumor has invaded surrounding tissues. The two main surgical techniques for treating pituitary tumors are endoscopic transnasal transsphenoidal approach. This usually enables surgery to remove the tumor through nose and sinuses without an external incision. No other part of brain is affected, and there's no visible scar. Large tumors may be difficult to remove this way, especially if a tumor has invaded nearby nerves or brain tissue. Transcranial approach, craniotomy. The tumor is removed through the upper part of skull via an incision in scalp. It's easier to reach large or more complicated tumors using this procedure. Radiation therapy. Radiation therapy uses high-energy sources of radiation to destroy tumors. It can be used after surgery or alone if surgery isn't an option. Radiation therapy can be beneficial if a tumor persists or returns after surgery and causes signs and symptoms that medications don't relieve. Methods of radiation therapy include stereotactic radiosurgery. Often delivered as a single high dose, this focuses radiation beams on the tumor without an incision. It delivers radiation beams the size and shape of the tumor into the tumor with the aid of special brain imaging techniques. Minimal radiation comes in contact with healthy tissue surrounding the tumor, decreasing the risk of damage to normal tissue. External beam radiation. This delivers radiation in small increments over time. A series of treatments, usually 5 times a week over a 4 to 6 week period, is performed on an outpatient basis. While this therapy is often effective, it may take years to fully control the tumor growth and hormone production. Radiation therapy may also damage remaining normal pituitary cells and normal brain tissue, particularly near the pituitary gland. Intensity modulated radiation therapy, IMRT. This type of radiation therapy uses a computer that allows the doctor to shape the beams and surround the tumor from many different angles. The strength of the beams can also be limited, which means surrounding tissues will receive less radiation. Proton beam therapy. Another radiation option, this type uses positively charged ions, protons, rather than X-rays. Unlike X-rays, proton beams stop after releasing their energy within their target. The beams can be finely controlled and can be used on tumors with less risk to healthy tissues. This type of therapy requires special equipment and isn't widely available. The benefits and complications of these forms of radiation therapy often aren't immediate and may take months or years to be fully effective. Medications. Treatment with medications may help to block excess hormone secretion and sometimes shrink certain types of pituitary tumors. Prolactin-secreting tumors, prolactinomas. The drugs cabergoline and bromocriptine, parlodal, decrease prolactin secretion and often reduce tumor size. Possible side effects include drowsiness, dizziness, nausea, nasal stuffiness, vomiting, diarrhea or constipation, confusion, and depression. Some people develop compulsive behaviors, such as gambling, while taking these medications. ACTH-producing tumors, Cushing syndrome. Mifepristone, Colim, Mifeprex, is approved for people with Cushing syndrome who have type 2 diabetes or glucose intolerance. Mifepristone does not decrease cortisol production, but it blocks the effects of cortisol on tissues. Side effects may include fatigue, nausea, vomiting, headaches, muscle aches, high blood pressure, low potassium and swelling. The newest medication for Cushing syndrome is pasireotide, Signifor, and it works by decreasing ACTH production from a pituitary tumor. This medication is given as an injection twice daily. It is recommended if pituitary surgery is unsuccessful or cannot be done. Side effects are fairly common, and may include diarrhea, nausea, high blood sugar, headache, abdominal pain and fatigue. Growth hormone-secreting tumors. Two types of drugs are available for these types of pituitary tumors and are especially useful if surgery has been unsuccessful in normalizing growth hormone production. One type of drugs known as somatostatin analogs, which includes drugs such as octreotide, sundostatin, and lanreotide, somatulin depot, causes a decrease in growth hormone production and may shrink the tumor. These are given by injections, usually every 4 weeks. These drugs can cause side effects such as nausea, vomiting, diarrhea, stomach pain, dizziness, headache and pain at the site of injection. They can also cause gallstones and may worsen diabetes mellitus. The second type of drugs, pegvisomant, Somvert, blocks the effect of excess growth hormone on the body. This drug, given by daily injections, may cause liver damage in some people. Replacement of pituitary hormones. If a pituitary tumor or surgery to remove it decreases hormone production, client will likely need to take replacement hormones to maintain normal hormone levels. Some people who have radiation treatment also need pituitary hormone replacement. Complications. Pituitary tumors usually don't grow or spread extensively. However, they can affect health, possibly causing vision loss. A pituitary tumor can put pressure on the optic nerves. Permanent hormone deficiency. The presence of a pituitary tumor or the removal of one may permanently alter hormone supply, which may need to be replaced with hormone medications. A rare but potentially serious complication of a pituitary tumor is pituitary apoplexy, when sudden bleeding into the tumor occurs. Pituitary apoplexy requires emergency treatment, usually with corticosteroids and possibly surgery.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.